In that first photo on the left, you'll see a blood vessel on the inside, right? You may notice it's very small, but if you pay close attention, there's a site of injury, right? It's like a hairline crack. Yo, what's happening, y'all? Welcome back to another video, and actually welcome to the video that's going to kick off my 300 series sessions. This here, the nutritional basis of disease session, and the first video I'm going to go over is atherosclerosis in that playlist. I want to go ahead and talk to y'all about atherosclerosis for a little bit. In my session 100 series, I did make a video about hypertension, right? And also cholesterol as well as diabetes. So, you know, those three are in a sense prerequisites for what it is I'm about to talk about. Atherosclerosis is one of actually the more common CVDs, which stands for cardiovascular diseases. You know, it comes in different forms. It's also another one of our silent killers. It can, you know, end up leading to heart attacks, strokes, you know, the common, you know, types of ailments and illnesses, you know, serious chronic, you know, illnesses. So some of the affected groups are, you know, so for African Americans, Hispanics, and white people, this happens to be one of the leading causes of death. For Asians and Pacific Islanders, as well as, you know, Native Americans or American Indians, this happens to fall second to cancer. So as you can see, atherosclerosis is a pretty big deal in this country. Healthcare costs, this is also what makes atherosclerosis a big deal. Unfortunately, healthcare costs, you know, it can cost anywhere up to over $400 billion in healthcare costs, you know, for services and for medication. What I'm gonna do now is I'm gonna put up a figure. It's gonna help me, you know, kind of talk a little bit about atherosclerosis and how it works. In this here figure, this basically describes the process beginnings, how it gets started, and you know, how it progresses on from there, the different stages of progression. What you're looking at is a blood vessel, right? It's the same blood vessel, just, you know, going through the different stages of progression for atherosclerosis. In that first photo on the left, you'll see a blood vessel on the inside, right? You may notice it's very small, but if you pay close attention, there's a site of injury, right? It's like a hairline crack. And what it is that's like inflammation or injury, right? It's the site of injury there. So what happens is your body sends monocytes out, which is essentially a form of white blood cells. As many of us may know, white blood cells is one of our more protective cells against illnesses, viruses, diseases, you know, things like that. And so white blood cells, our immune system typically sends those out, you know what I'm saying, whenever we're feeling some type of way, when we come down with an illness, it expends white blood cells to help us get better and help us improve in health. There's monocytes that come to the site of injury, and the next stage, right, the middle picture now is what we're looking at. The next stage of progression for atherosclerosis, you then beginning to form what's called plaque. Now, I talked about this in my cholesterol video, right? You might have remembered me mentioning terms like LDL, HDL, you know, triglycerides, things like that. Specifically, atherosclerosis, it focuses more so on LDL increases, but, you know, all the other, you know, components of a lipid panel, that being total cholesterol, HDL, and, you know, triglycerides, they all still come into play with atherosclerosis just as much as it does, you know, having high cholesterol and dyslipidemia. What you see is the monocytes, those white blood cells, they end up kind of tucked into the artery walls, right? So they slip under the blood vessel in the arterial walls, and what happens is they then, the more plaque they tend to, or I should say, the more LDL they start to accumulate, that forms, you know, that's the first stage of plaque formation, right? What happens is they become foam cells, or otherwise they're known as fatty streaks. So what happens is, as they slip under the blood vessel and they accumulate LDL, the arterial wall may expand to help accumulate that plaque, but if it gets to the point where it's too much, obviously, you know, those fatty streaks are going to thicken and they become plaque. And the more plaque you have over time, more plaque buildup means more blockage in your arterial walls, which of course means less blood flow. Now I want to go into what this all, like the more, I guess, sort of chain of events that can come from this. So you can have what's called aggregation of platelets due to inflammation. Platelets are they're like colorless cells that our body, sends out to essentially help stop the bleeding, right? So if at a site of injury or what have you, it helps to stop the bleeding. The problem with that is, it's important to ensure you don't have a high platelet count, because a high platelet count, which, of course, is a part of plaque progression too. The higher the platelet count goes, the higher the aggregation of platelets, you can form what's called sticky plaque. And the reason why that's bad for you essentially is because, see, platelets, they can contribute to atherosclerosis by essentially ultimately damaging your endothelium area, right? Your vessels or vascular endothelium, you know what I'm saying? So you can end up damaging your blood vessels basically. The more damage to the blood vessels, the more inflammation essentially is prolonged, the more, LDL is allowed to accumulate, more plaque, and you get the picture, right? So on and so forth. It just continues into a, chain of events, just kind of compounding on top of each other, one issue into another. Also, I want to talk about thrombus. Monocytes, their fatty accumulation, right? Another thing that can happen, right, is the destabilization of plaque, okay? The destabilization of, LDL lipids. So what can happen here is thrombus. It's a blood clot that could form essentially in the arterial walls, but it doesn't have to just be in the area around your heart, okay? Blood clots also can form in the brain too, causing embolisms over time, okay? So thrombus doesn't have to just cause heart attacks and strokes, which they do, okay? Thrombus, can lead to heart attacks and strokes, but also embolisms, because blood clots can travel to your brain, right? They can form in the blood vessels that's up in your brain too, in addition to pulmonary. Thrombus essentially it consists of pro-inflammatory properties, right? And platelets, unfortunately, too. As much as we do need platelets, a high count also leads to a release of, I believe it's called cytokines. I think that's how you pronounce it. It's basically pro-inflammatory properties. So as y'all know, when you hear the word pro, that means in support of something, usually, right? You're pro this or pro that. So cytokines, that's what gets released. It's a pro-inflammatory property of platelets. And obviously, as I mentioned, more inflammation, more prolonged inflammation allows atherosclerosis to eventually, go ahead and come to fruition over time. Then that last thing I want to talk about here in this process is nitric oxide. I do believe it was hypertension though. I talked about nitric oxide, and what that essentially is it's something that our bodies help produce to help regulate, platelets and things like that. It helps regulate all the things that lead to atherosclerosis. It helps to regulate the monocyte, production, as well as platelets. Risk factors. Now, some of these risk factors you may notice are modifiable and others not so much. The first ones that are listed, the first two, are non-modifiable, right? So genetics and family history, that's essentially non-modifiable, which means it's something you can't do nothing about that. You can't modify it, right? Our family history and genetics is what it is. Now, I wanted to write, because I wrote in parentheses here, I wanted to use my community as an example and talk about how it relates to gene expression. So, genetics and family history, my community. So, my VA doctor, each annual appointment that I have with him, he reminds me, I guess I should say, every time we talk about my dyslipidemia, which essentially is, high LDL, one of the things we talk about is a theory that ties back to slavery for, black folks, and how the conditions that were conducted in slavery, how that may have modified gene expression, not so much DNA coding, right? That's completely different. But it may have modified our gene expressions for generations to come, right? Gene expressions such as the way that we're able to manage stress, because you can imagine in an environment such as slavery, you can imagine that it was, this is putting it lightly, right? This is putting it very nicely, but stressful. Now, some of y'all may know our bodies have ways of releasing cortisol, which is supposed to be, supposed to help us manage stress. In instances of slavery, that made it much more difficult for us to be able to release cortisol and to manage the stress that was brought upon, people. So what that essentially did was it modified gene expression. and it just passed down through generations. So essentially, like, you know, also when they would, you know, breed the strongest black man and the strongest black woman together, you know what I'm saying, they breed them, you know, and have them have kids, you know, to continue the transatlantic slave trade, things like that, you know, definitely didn't help our case out either, because, you know, some of the issues that same man and woman had obviously passes to the kids. And then when those kids have kids, you know, it just passes down through generations. So it's something that my doctor and I, you know, frequently go over pretty much, you know, annually each time I see him. You know, it's a theory, I guess, that they learn in medical school, you know, from what he said. It's something that we'll forever likely pay with for the rest of our lives. So it's very unfortunate. You lead on to age and sex, right? So for atherosclerosis, people over the age of 65, as well as males, typically are the most vulnerable. Males, they catch atherosclerosis usually, or develop, I should say is the right word to use. I don't want to say catch, but males develop atherosclerosis usually at a faster rate than females. However, females who have hit menopause already, you know, they can be more at risk, right, than a female who hasn't hit menopause yet, and those that are still in reproductive stages and ages. Obesity, right? It's a direct proportionate relationship. However, there is something else that I recently learned about. It's called LMHR. That could also apply here too. What that stands for is lean mass hyperrespondence. So what that is there are people who, you know, have more leaner mass and also still have high cholesterol. But see, now the thing is, they could be, you know, lean, right, as a result of them working out and, you know, the things that they eat. But lean mass hyperrespondence typically tend to be associated with diets that are more ketogenic or just lower carb in general. So of course, when, you know, as I talked about, you know, previously in my dieter types videos, when you do a ketogenic diet or even just like a low carb diet and you're increasing fats, essentially supposed to be metabolizing fat as fuel, assuming that, you know, your body is using it as fuel. You know what I'm saying? Like it's got to use it as such. So basically what I'm saying here in this bullet is, you know, obesity of course is a risk factor, but what I'm saying is you don't have to be obese in order to have atherosclerosis. You could still be smaller and leaner, you know what I'm saying, and still get atherosclerosis. Then the next thing is physical activity, right? Inactivity, I should say. So physical inactivity is a risk factor. And so I've also talked about that too. You know, when you're not physically active, you know, you're not exactly burning, you know, fats and let alone carbs. But atherosclerosis is more associated with fat, but of course physical activity is just one factor, and it is a modifiable factor. Same thing with obesity. Hyperglycemia, which means, you know, you have your glycemic levels are pretty high, right? So that can, the reason why that's a contributing factor for atherosclerosis is because hyperglycemia can essentially damage blood vessel linings. I wrote cigarette smoking. When you smoke cigarettes, you know, it reduces the amount of nitric oxide, or it hinders your body's production of nitric oxide, and also damages blood vessel lining as well. It can constrict your blood vessels, damage the lining of them, you know, the endothelium area, and nitric oxide, as I talked about, that's the one thing that can help, you know, regulate all of the you know, release of the monocytes and, you know, of course the platelets and all of that stuff. Progression, it's not like it's gonna happen immediately, but, you know, if you could maybe reduce smoking or, you know, get to a point where you could stop, that's what I would suggest. So, you know, it is a risk factor, and again, modifiable at that. The last one I wrote was hypertension and dyslipidemia. For obvious reasons, dyslipidemia is basically, you know, it's when your cholesterol is high, but specifically LDL, right? That's what the focus is. But it can be that you have high triglycerides. It can also be that you have high total cholesterol, and that you have very low HDL, which is the good cholesterol. You know, but dyslipidemia does tend to focus more on LDL cholesterol and the increase of such. Then you have hypertension, right? Hypertension is also something that deals with blood vessels. Hypertension is high blood pressure. So when your blood pressure is high, you know, your body's working, you know, much harder to pump blood, which is definitely not going to help your case if you got inflammation that your body is trying to send white blood cells and platelets out to, you know, try to repair and fix. And that's going to lead me into the next section. Things that we can, you know, the modifiable risk factors, what it is that we can do about that. So now the next section I have is the nutrition therapy, right? So nutrition therapy here I have, first thing, obviously, this is more so preaching to the choir. A lot of you may already know this, but there's going to, of course, have to be an evaluation of sorts first, okay? So they'll evaluate the condition, they'll go over medical history, of course, your diet, what it is you eat, they go over all of that. No different than what they may do in an annual exam, right? When you get blood work done, they see high levels, and then, your doctor may suggest what it is that you can do to help lower said levels of whatever is high. It will normally aim to conduct the following bullets I wrote here. So the first thing I wrote was to increase soluble fiber. So what happens with soluble fiber, and you may hear this a lot, eat more fiber, right? Eat more fiber. Well, there's a reason why that gets said. Soluble fiber specifically, it helps create a gel, right, in the digestive tract, and that gel attracts like all the bile and the LDL that comes through, and so that your body doesn't absorb LDL, right, the gel that's formed from the fiber does, and then it forces your liver to take that LDL and all that bile and cycle it through. That's essentially what HDL also does, the high density lipoproteins. HDL is it's in direct relation in a sense to LDL, right? What happens is your liver, because most people know our liver is that's the organ that helps filter out that, and our kidneys helps filter out excess waste and things like that. The liver is what comes into play here in getting rid of the LDL. Then the next thing it says here is to increase fish serving. That's actually kind of in line with the next couple of bullets after that. Reduce saturated and trans fats, as well as increase unsaturated fats, so that being poly and mono unsaturated. So in a previous video in my 100 series sessions, I talked about how there were certain foods that had mono and poly unsaturated fats. Fish is just one of them, right? Fish has what's called omega-3 fatty acids, or certain fish does, like tuna, mackerel, salmon, red herring, just as an example. Those have what's called omega-3s, which is a mono unsaturated fat that can help lower LDL and increase HDL. Also, saturated and trans fats, as most of y'all know, that tends to come from a lot of processed and ultra processed foods. It does also come from certain meats. And again, I'm not that kind of guy that's going to tell you to stop eating meat, okay? I would just say maybe alter that meat out every now and again when you can, you know what I'm saying? Like eat more seafood, provided that you don't have an allergy for it, okay? Because that's the one thing here that, I wanted to also say with increasing fish servings. Obviously, if you have an allergy to seafood, that may not work really well for you. So luckily though, there are other items that have omega-3s in them specifically, and mono and polyunsaturated fats that can help lower LDL cholesterol. So another food is nuts, right? Now again, if you have a nut allergy, that's not going to help you either. But if you don't, almonds, walnuts, cashews, just peanuts like that, they'll help lower LDL. There's also certain oils, right? Olive and avocado oils. Those are the oils that I love to cook with, you feel me? So with olive and avocado oils, they also have mono and polyunsaturated fats. If you cook a lot, try to cook more with those oils. And if you are gonna cook with like butters or what have you, maybe try cooking with more margarine if you can. It's still gonna have some saturated and trans fats in it, but it won't have nearly as much as butter will. Definitely, try to minimize canola, coconut, and try to minimize those types of oils, okay? And even like certain other seed oils. I'm not saying, don't, mess with them completely. I'm not saying swear off of them, but just minimize them, Like just be mindful of how much you cook with those. And I do use grapeseed when I can, right? Grapeseed, I don't use that a whole lot, but grapeseed does have a mono and polyunsaturated fat content in it, so, But just like with anything else, if you use a lot of those oils, even whether it's avocado, olive, or even grapeseed, they still do have total fats in them, They still are, they do have fatty content. So you still do want to be mindful of how much you use. There's nuance there, and I'm gonna go into that at the end. The next thing I have here is to reduce sodium intake. So most of y'all know from my hypertension video, I talked about how hypertension is closely related to high sodium intake. So of course, the more sodium that your body has, sodium also can contribute to obesity as well, which is a risk factor for atherosclerosis. Sodium, when you intake a lot, right, when you overconsume in excess, what happens is, your body retains that sodium, and especially happens when you don't have enough water, right, in your system. when there's not enough water in your body, your body will retain sodium and try to counteract that imbalance. Reduce refined carbohydrates. That also is pretty much a given. Like, that's an obvious one, right? Carbohydrates, an increase of such can lead you to hyperglycemia. It can lead to diabetes, if you're not careful. You have more than your body knows what to do with. Your body will then take those carbs and just convert them over to fat stores, and it'll leave the fat stores in your body. See, the thing about carbs, right? Carbs don't stay in your body for very long, at least not like fats do. Fats, they stay forever until you metabolize them. Then the last thing I have is increased physical activity, which, as we all know, is another obvious, it's another given. It's recommended that most healthy individuals, right? The average healthy individual should do 150 to 300 minutes per week of moderate intense cardio. There is another option though that I have talked about in the past, and that is 75 minutes per week. But that 75 minutes, that has to be high intensity cardio. So you can end up doing HIIT, you can do like sprints, like high intensity plyometrics, jumping, because that's high impact. Even doing the stair stepper at a fast pace, that's high intensity, right? Same thing with the elliptical. When it's at a fast and a high pace, that's high intensity. So, 75 minutes of that you can do. But if you're gonna do moderate cardio, moderate intense cardio, so like if you're gonna do the stair stepper for like a more moderate, stepper level, you gotta do about 150 minutes of that per week at the lower end, and 300 minutes at the high end, to help get your blood flow, increase your blood flow and to help cycle out more of the LDL that your body may have. Now, we're gonna go into the last part of the nutrition therapy. We have the 5 A's, that is assess, advise, agree, assist, and arrange. What all this means is the assess is basically, that's the assessment part of the A's, right? The assessment is, they'll go over like your biochemical analysis, right? So basically they'll just evaluate you. They'll get your BMI, your weight. They'll see what your diet is like, what you're eating, and maybe that'll give your doctors an idea, or nutritionists, if you're working with one, a dietitian, that gives them an idea as to like what to take away from your diet, as well as like what to add more of. They personalize it for you. And so that's the advice part, actually. The advice part is where they personalize, a behavior for you that, you should be following in order to help reduce your risk of atherosclerosis and death. They're gonna advise you to, maybe do some of these things up here. Increase fish servings or what have you. Provided you don't have a seafood allergy, they may tell you to get more exercise. Then there's the agree. So the agree is basically where, you make sure that the patient, as well as the dietitian or nutritionist or doctor, whoever, agrees, okay, that the plan that's been set in motion is what is to be followed. Now, there may come a time, of course, obviously, where patients, they may be reluctant to agree. So a response may be like, okay, let me ask you this, let's touch this topic next visit. Because it may be a case where a patient, will have a little bit of trouble. It may not be that they don't want to do it. It may be, it could be that they don't want to do it, right? But it may be that they're having a little bit of trouble. And maybe they need, more of a support system or whatever the case may be, right? There's a whole lot of other factors that go into just putting a plan together for somebody. A patient doesn't want to necessarily feel like they're just another number on a spreadsheet or something like that, So that's where the agree will come in. And also the assist. So that's where also the assist will come in. I kind of already talked about that just now, but that's the support system I was mentioning, right? The assist, if the patient needs any kind of assistance and need, more like info, what have you, that's where the doctor's supposed to come in and say, tell and just kind of give them some ideas. Example I can give for assist maybe, and it's an example I come back to a lot. It really is. I know it's likely repetitive, but I always look at my 600-pound life. Of course, they go see Dr. Now, and Dr. Now puts them on a plan. Usually it's low carb, high protein, things like that. Sometimes the support system they have doesn't always, pan out, because sometimes those patients on my 600-pound life may have a support system that, enables them, to just do whatever it is that they've been doing that's not working, and doesn't push them to do better. But it may be the complete opposite. It may be that they have, some sort of support or some sort of motivator, right? Some sort of factor that they have in their life to, help them actually follow a plan. That's an example I could come up with, my 600-pound life. The arrange is basically where, the patient and doctor will arrange their next visit, right? They'll arrange a follow-up visit to go over results and, go over the wins as well as the losses, and then see what happens for, what they need to come up with so that the next visit can be made. That right there is going to cover atherosclerosis, y'all. So before I go, this session 300 series, as I mentioned, if you follow my Instagram, this is all about nutritional basis of disease. So what this series is going to talk about is, I'm going to talk about certain diseases, certain cancers, things like that. And I'm going to go over the nutritional basis for it. Okay, so just the nutritional basis. Obviously, I'm not naive. I know that there's diseases and cancers that we get that nutrition has nothing to do with, right? Nutrition is simply just a factor. It's not the only one. So I just want to go ahead and put that out there. I want y'all to know that I'm not just talking about, okay, eat more of this and less of that, and then you won't get atherosclerosis, or you won't get esophageal carcinoma, or whatever, cancer. You know what I'm saying? That's not what this is. This is simply, going over said diseases and infectious illnesses or what have you, and, going over how it relates to, nutritionally, what you can do about that. Anything else, of course, would have to be, you have to go to a doctor. And that's what this series is going to be about. And I appreciate y'all for tuning into my first 300 series session. This has been atherosclerosis. I will catch y'all on my next video. And until next time, y'all take care and have yourselves a great one.